cardiovascular physiology. So for the pressure volume loops, it's going to be hard without a visual. So I'd recommend putting the pressure volume loop in front of you with the cardiac cycle and the Wigger's diagram. But just from the beginning, at the bottom right corner of our pressure volume loop, okay, we're going to have S1 sound, okay? And that S1 sound indicates the mitral and tricuspid valves are closing. And right when the mitral and tricuspid valves close, that means that we're about to start systole, okay? And so we see a rise in the pressure volume loop of our left ventricular pressure, but no change in the left ventricular volume. It's usually just a straight line up, okay? And that indicates isovolumetric contraction, where there's no change in the volume, but we're starting to increase the pressure, preparing to leave the ventricles, okay? Preparing for the blood to leave the ventricles. The upper right portion, okay, is right when we're gonna hit the release, okay? So that's when the aortic valves open and the pulmonic valves open. And we shoot the blood out into the systems, okay? And the upper left portion is where we're gonna see afterload. If we increase the upper left side, okay, if we make it taller, we make it larger, that means we're increasing that pressure. The left ventricular pressure is gonna rise, so that means that we increase afterload, okay? At the end of that curve in the upper left corner, we're gonna see or hear S2. And S2 just means that the aortic and pulmonary valve are closing, marking the end of systole and starting diastole. And to begin diastole, we must relax the ventricles, okay? And the way that we do that is through isovolumetric relaxation, where we're decreasing that left ventricular pressure, okay, overall, but there's no change in the left ventricular volume. We're not getting any blood yet. We still need to drop below the atria, the pressures of the atrium, in order to get that blood in. Once we drop low enough, then the atrium is gonna fill the blood into the left ventricle, okay? And that's when we're gonna hear our S3 and S4, which are mainly pathological, okay? The S3 is usually in early diastole, and it's during rapid ventricular filling, okay? And it's best heard at the end of expiration when the heart is closest to the chest, okay? It's associated with increased filling pressures, but it could be normal in young adults, children, and athletes, as well as in pregnancy. However, S4 is right before that S1, so right before you reach that bottom right corner of the pressure volume loop, and that's always pathological, okay? It's heard late in diastole, and we know it as the atrial kick, okay? And it's due to the fact that we have turbulence, okay? Because blood that enters the ventricle is gonna hit a stiffened wall, a stiffened left ventricular wall. And that's gonna denote left ventricular hypertrophy, okay? Mainly ventricular non-compliance, okay? S3 is mainly associated with dilated cardiomyopathy, okay? Now, moving forward, the splitting of S2. So S1 and S2 are our heart sounds that we already discussed, where S1 is the mitral and tricuspid valve closing, and S2 are our semilunar valves closing, our aortic and pulmonary valves closing, okay? And what we need to understand about that is that there is normal physiological splitting of the S2 sound, okay? And what does that mean? That means that the aortic valve will always close before the pulmonic valve, okay? And it changes depending whether you're inspiring or expiring, okay? So whether you're breathing in or breathing out, it's going to change. So normally, physiologically, on expiration, the A2 is right before the P2. So our aortic heart sound is right before our pulmonic heart sound. And then on inspiration, when we inspire, okay, we take in all this air and we cause blood to flow through the right atrium quicker. So blood comes from the veins and it flows into the heart quicker when we inspire. That means there's going to be more blood on the right side. And since there's more blood on the right side, that means there's going to be more blood passing through the pulmonic valve. Hence, it's going to take longer to close. So we see a widening delay between our aortic sound and the pulmonic sound. So that's where we see our physiologic A2 and P2 splitting. Now, what's very important is that we can have pathological splitting. So where we have an abnormal delay. So there is a normal delay, but if we extend that delay for too long, then it can become pathologic. And one of the main high yield things that we need to know is that if there's a fixed wide split, okay? So regardless of inspiration or expiration, okay, my splitting is not going to change. Secondly, it's going to be wider than the physiological split. So that's why we give it the wide fixed split name. And that is going to be seen in our ASDs, okay? And that's going to be atrial septal defects. And one of the atrial septal defects that we know already is the patent form in ovale, okay? So if you have an ASD, you're going to hear a wide fixed split of the S2, okay? And once again, this is going to increase our risk for paradoxical emboli because we have the ability to shunt from right to left, okay? Next is auscultation of the heart. So the best way to know the auscultation of the heart is that on the right side in the second intercostal space is our aortic sound. Left side intercostal space, second intercostal space, is our pulmonic sound. Then as we move down, we're going to have the tricuspid close to that sternal border. That's going to be the tricuspid sound. And all the way down, okay, in the fifth intercostal space, we're going to have the mitral sound, okay? And they'll say fifth intercostal space mid-clavicular because it's in the mid-clavicular line, okay? You have to memorize where each heart sound is going to be located, but we're going to walk through that. Okay. So the first heart sound is going to be the heart murmur, I guess I should say, is our aortic stenosis, okay? And these are all going to be heard in systole. The first is going to be all heard in systole. So aortic stenosis is the number one thing that we need to know. And this is going to be crescendo, decrescendo ejection murmur. So it's going to be heard between S1 and S2. And that makes sense because during aortic stenosis, we have the aortic valve not able to open at the normal pressure. So the left ventricle has to increase in pressure in order to achieve ejection of blood. So we have a crescendo, decrescendo ejection murmur, okay? And this is mainly due to, okay, two things. If we see it in an elderly patient, it can be physiological because as we age, we get calcifications of the valves. And so it makes it harder to open up the aortic valve. So aortic valve compliance has decreased. So that's one way that we can get aortic stenosis and see this crescendo, decrescendo systolic murmur. Number two, if you see a crescendo, decrescendo systolic murmur, okay, aortic stenosis, in a younger patient, you're going to mainly think of a bicuspid aortic valve. So bicuspid aortic valves, usually our aortic valves are tricuspid. However, if we have a congenital abnormality where the aortic valve is a bicuspid valve, then we have an increased risk for early onset calcification, okay? So we get early onset aortic stenosis. And that's mainly going to be seen in patients with Turner syndrome, okay? Turner's is one of the main pathologies associated with early onset calcification due to bicuspid aortic valve. And that's going to lead to the aortic stenosis. Okay. Now the aortic stenosis is best heard in the second intercostal space on the right side. Okay. And they will say that it's going to radiate to our carotids. Okay, that's one of their favorite things to say. Number 2, our second systolic heart murmur, is mitral and tricuspid regurg. Mitral and tricuspid regurg are both going to sound like holosystolic, high-pitched blowing murmurs. So there's only 3 things that causes holosystolic murmurs. This is 2 of them. Mitral regurgitation and tricuspid regurgitation are 2 of the 3 things that cause holosystolic murmurs. VSD, our ventricular septal defect, is the 3rd that causes a holosystolic murmur. So the question is, how can we differentiate these? The mitral tricuspid regurg is going to be high-pitched, whereas the VSD is going to be harsh-sounding. Okay? So mitral tricuspid regurg, both of those, are going to be holosystolic high-pitched, whereas VSD is going to be holosystolic harsh-sounding. Okay? Very important. Now, for mitral regurgitation, what we need to know is that the high-yield pathology associated with it is going to be acute rheumatic fever. Acute rheumatic fever. Okay? And that just means that if we have rheumatic fever and a patient has a murmur that's less than 25 years of age, they're going to have mitral regurgitation. Okay? Tricuspid regurgitation is associated with IV drug users who have infective endocarditis. Next is going to be mitral valve prolapse, and this is our last systolic murmur. Okay? And the mitral valve prolapse is going to be mitral valve pro-click. Okay? So you're going to have a non-ejection click, which is very important. So in between S1 and S2, you'll hear a click, and then you'll hear a crescendo murmur until you reach S2. This is very common in young women as well as patients with Marfan's disease. And Marfan's disease is just due to myxomatous degeneration, okay? So it's just connective tissue disorder, okay? And it has myxomatous degeneration, which leads to issues with the valves, specifically the mitral valve. So that's where we're going to see mitral valve prolapse with young women or patients with Marfan's. So just to round it all out, systolic murmurs are aortic stenosis, which is going to be crescendo decrescendo. Next is going to be mitral tricuspid regurg, which is holosystolic high-pitched. Next is VSD, which is holosystolic harsh sounding. And then last is mitral valve prolapse, which has a click and then a crescendo murmur, and it's seen in young women or Marfan's patients. Next, I'll be moving on to our diastolic murmurs, which occurs after S2. So aortic regurg is number 1. So once we're done with systole and we've ejected all the blood into the aorta, some of that blood can trickle back down if we have aortic regurgitation. And that's during our diastole. So that's why it causes a diastolic murmur. So aortic regurgitation is going to be a decrescendo, high-pitched blowing sound. Okay? Now, this is best heard when the patient sits up and leans forward at the aortic site. And there's 4 things associated with it. Bicuspid aortic valve, even though that's highly associated with aortic stenosis, it can be associated with aortic regurg. But the main thing that I care about is the aortic root dilation can cause aortic regurg, and that is seen in Marfan's. Okay? The patient's going to present with widened pulse pressures. So pulse pressure is just systole minus diastole of our blood pressures. And so if we have a very, very high systolic blood pressure and a very, very low diastolic blood pressure, okay, we know that there's a widened pulse pressure, which is indicative, highly indicative of aortic regurgitation. Different ways that they could say that is you're going to see rapid rise and fall of the arterial pressures. That's just another way of saying it. You also can see pistol shot femoral pulses and pulsating nail beds. Head bobbing is also a very high yield association with aortic regurg. Next and lastly of the diastolic murmurs, there's only two, aortic regurg and mitral stenosis. So mitral stenosis is stenose snap. Okay, so there's going to be an opening snap following S2. Okay, and this is highly indicative of chronic rheumatic fever. So if you see a patient with rheumatic fever that's greater than 30 years old, then they have mitral stenosis. If you have a patient with rheumatic fever that has less than 25 years old, then that's going to be mitral regurg. Okay, so stenosis is going to have that opening snap followed by a rumbling mid to late murmur. It also is highly associated with a loud S1. Okay, so let's go over the diastolic just to round that out. Diastolic murmurs, we have two. Aortic stenosis, which is associated with a decrescendo high-pitched blowing after S2, and it's highly associated with aortic root dilation seen in Marfan's patients. And it's indicative, if you can see it, with wide pulse pressures, pistol shot femoral pulses, pulsating nail beds, or head bobbing. Mitral stenosis is the second diastolic murmur, and it's following S2, we hear an opening snap with a rumbling mid to late murmur. Very associated with rheumatic fever, chronic rheumatic fever, so late rheumatic fever. Lastly, the only one that has continuous murmur is our patent ductus arteriosus. So if you see a murmur that's both in systole and diastole, so holosystolic, holodiastolic, just throughout everything, continuous machine-like murmur is how they'll say it, then you know that it's a patent ductus arteriosus, and it's associated with congenital rubella, among other things. Next, moving on, is the electrocardiogram. What we need to know is the locations and the conduction pathway, as well as the speed of conduction. So the conduction pathway, normally it goes from the SA node to the atria, and then the AV node to the bundle of His, to the right and left bundle branches, to the Purkinje fibers, and finally to the ventricles. Now the SA node, we have to know that it's located at the crista terminalis near the SVC opening. And this is our pacemaker of the heart. So this runs our heart rate. The SA node is very important for our heart rate. The AV node is located in the intraatrial septum near the coronary sinus opening. Okay? And the blood supply for both of these is going to be our dominant artery. Okay? The AV node has a delay, however, because it needs to allow the ventricles to fill. Once it receives the electrical impulse, it will delay just so that the ventricles can fill with blood. Once the ventricles fill with blood, the AV node will go, allowing the blood to be released. Okay? The pacemaker rates, so this is what decides our heart rate, is going to be the SA node is first. Then if the SA node is knocked out, then it will be the AV node. Speed of conduction is very important. So how fast are we going to be conducting electricity? The fastest is going to be His Purkinje fibers. Then it's going to be the atria, then the ventricles, then the AV node. We know the AV node is going to be the slowest speed of conduction, okay? Due to the fact that we have to have a break in between in order for the ventricles to fill, okay? Lastly, they're going to expect you to understand the P wave, the QRS complex, and the T wave of the EKG, okay? And what it's important to note is that the P wave, okay, is due to the fact that we have atrial depolarization, okay? The QRS complex is ventricular depolarization, and then the T wave is ventricular repolarization. That's all that it is. So once again, the P wave is atria depolarizing, the QRS complex is the ventricles depolarizing, and then the T wave is going to be the ventricles repolarizing. Now, they can ask you to measure the heart rate by just looking at an EKG. All you have to do is take the RR interval. So take that high peak at the R and go to the next R. And that's your RR interval. And all you have to do is count the number of boxes in between, the number of large boxes in between, okay? And then you take 300 divided by the number of boxes in between each RR interval. So if you have one R interval and then the next R interval isn't until, let's say, 3 large boxes, that means that we're going to take 300 divided by 3, so our heart rate is going to be 100, okay? If every R interval is just one large box, so we just take 300 divided by 1 and our heart rate is 300, okay, which is very, very fast. Next is going to be the baroreceptors and chemoreceptors. All we have to know about this is that our carotids are going to send via the glossopharyngeal nerve, and our aortics are going to send via the vagus nerve, okay? Understand the chemoreceptors and the baroreceptors. They can ask specific questions about those, but I won't be going into full depth on that. Lastly is going to be our normal resting cardiac pressures. We use a Swan-Ganz catheter in order to measure the pressure of the heart. And what we need to understand is at every single moment in the heart, what is the pressure? The first thing is the right atrium is going to have 5 millimeters of mercury. The right ventricle is going to be 25 over 5. And that the pulmonary artery is 25 over 10. So let's take a pause. The best way to remember this is that right ventricle has to be able to go high enough to bypass, increase, right, past that pulmonary artery pressure. So that's why systolic, it has to be 25. But it has to get low enough in order to be filled again from the right atrium. So that's why its diastolic is 5. So if you know the right ventricular pressure, you're going to get the right atrial pressure and the pulmonary artery pressure. So once again, the right atrial pressure is going to be 5. So that means the right ventricle diastole is going to be 5 and systole is going to be 25. So RV is going to be 25 over 5. Pulmonary artery is going to be 25 over 10. Okay? That same concept works on the left side of the heart. Our PCWP, which is just our left atrial pressure, same thing, is going to be 10 millimeters of mercury. Our left ventricle has to be able to go as low as 10 millimeters of mercury, okay? But it also has to go as high as 120 millimeters of mercury because that's the aorta. So the aorta is 120 over 80, the left ventricle is 120 over 10, and the PCWP or the left atrium is going to be 10.